Thank you for coming this evening. Before I introduce our guest speaker, I would like to make a few remarks about gun violence in the U.S. and efforts to reduce it. I've been working on gun violence prevention for the past 10 years through the faith community and with national, state, and local organizations. Gun violence has been rising steadily in the U.S. since 2010, reaching unprecedented levels in 2021 during the COVID epidemic, when nearly 50,000 Americans were killed by firearms. In 2020, firearm injuries became the #1 cause of death among children and teens in the U.S. Since 2021, gun violence has been declining slightly. In 2022, gun deaths were down 1% from nearly 49,000 to just over 48,000 deaths. Gun homicides are declining, but gun suicides are still increasing. Gun injuries, which are often not mentioned or emphasized in the media, are estimated to be 2 to 3 times gun deaths. So well over 100,000 Americans are injured by firearms annually, in addition to nearly 50,000 gun deaths. Harvard Medical School estimated the cost of gun violence in the US to be over $500 billion, including short and long-term costs to the economy. Many states have passed sensible gun laws, while other states have loosened gun regulations. But there is one especially good piece of news. After a nearly 25-year ban on government funding for gun violence research, after the so-called Dickey Amendment was passed by Congress in 1996, Congress allocated $25 million for gun violence research by the Centers for Disease Control and the National Institutes of Health. Dr. Hoops will talk this evening about how medical research is tackling the gun violence epidemic. Before I introduce Dr. Hoops, I'd like to just say a word about the evening's format. She will speak for 10 to 20 minutes, and then we will open it up for questions and answers. It is now my great pleasure to welcome and introduce Dr. Katherine Hoops. Dr. Hoops is an associate professor of pediatric critical care medicine at Johns Hopkins University School of Medicine. She received her medical degree from the University of Miami Miller School of Medicine in 2011, while at the same time getting her Master's of Public Health at the Johns Hopkins Bloomberg School of Public Health. She also has a law degree from Georgetown University Law School. In 2018, Dr. Hoops joined the core faculty at the Johns Hopkins Center for Gun Violence Solutions. The center uses a public health approach to conduct rigorous scientific research to identify a range of innovative solutions to gun violence. Please join me in welcoming Dr. Hoops.
Thank you all so much for having me. I'll bring this a little closer. Thank you all so much for having me. Really happy to be here and to get to talk to y'all. I've probably over-prepared on the slides, so honestly, put your hand up, ask questions anytime, because I hope that we'll provide some, kind of constructive and good discussions with the presented material too. So feel free to interrupt, honestly, at any point. We'll make sure you get a mic too. So this is me. As required, I have no conflicts to disclose, but kind of following on Chris's introduction, I am funded by the NIH and CDC, and so I will be talking about some of that research that's federally funded over the course of the next few minutes, and do also want to provide that we all come to this event this evening with different experiences, and that informs how we perceive and interpret material that we're exposed to. So just want to do disclose, we are going to be talking about some potentially triggering material, issues around structural racism, interpersonal violence, and suicide. So of course, you know what you need for your emotional well-being. And if you need to excuse yourself at any point or have questions or concerns, again, attend to your needs. So thank y'all. Okay, so Chris had asked me to comment a little bit more too on what my path was to this work. And I'm an intensivist physician. I see children who are, critically injured by firearms. So, that connection may seem, pretty logical, but the story starts a lot earlier. So this little slice of heaven in the middle there is the White Oak Creek Hunting Lodge. And that's where I spent a lot of my time growing up. I don't know if you can detect the accent. I am from Alabama. And, I grew up the daughter of the military and on a hunting camp that I still co-own with my uncles. So I've been around firearms my whole life. And, when I was a medical student, I was seeing patients who were being injured by firearms and colleagues who were not nearly as comfortable as I was talking about guns and gun safety. Then I went to Birmingham for my pediatrics residency, where many of my co-residents were firearm owners. And we were a lot more comfortable talking about firearms and safety. And I also then got to see that families are really receptive to this counseling. So then how do we bridge that gap, right? How do we help clinicians to become more confident delivering counseling on firearm safety? And so that's what I do in my research, is develop educational tools and programs. But the more time you spend in this space, you realize that all the child access prevention laws in the world are not going to solve the root causes of violence. And so that was why I went back to law school in an effort to bring those policy solutions and legal remedies for some of those structural determinants of health that we then encounter in a clinical setting. So that's kind of my pathway. And, I share this is a graphic from Cities United that I just think is perfect. Doesn't, I know y'all in the back can't see all of the detail on this, but really, kind of in testimony to my path here too, right? As a firearm owner and a clinician, and then kind of a, novice legal scholar, this requires a multi-sector approach, right? We all have to work together. Call it kind of an all hands on deck approach. So a lot of the things that we're talking about are, translational multi-sector projects. And again, it requires all hands to address this really complex issue. These are objectives. We're going to talk a little bit of data. We're going to talk about some risk factors. We're going to talk about some conceptual frameworks, including what is the public health approach, right? And then I'll talk a little bit more specifically about my research on communicating with families and how that looks in a clinical setting. So I think, Chris, you already spoke to some of this data, right? That we see that firearms are the leading cause of death in children in the U.S. And in fact, if you separate out, crash-related deaths from, all motor vehicle-related deaths, firearms have actually been the leading cause of death in children since 2017. So I think that, this is just really important to keep in mind, and especially important to me as a pediatric clinician. So let's zoom back out a little bit, and I'll add our final report on the 2022 data will be forthcoming now that data has finalized. We'll review in the course of the next few minutes is the 2021 data. So again, 48,830 lives were lost to firearms in 2021. So this is showing all ages. And so that's about 54% of firearm deaths among all ages were suicides. And then the orange section represents homicides, about 45% of gun deaths. Now, if I were giving this talk in 2017, that wedge would be about 35%. But because of those really incredible increases in gun homicide rates that we saw, 2019 to 2020 and 2020 to 2021. Now, we're looking at much higher numbers of homicides contributing to that overall number of firearm deaths, and then a larger proportion of firearm deaths due to homicides. Those smaller wedges up at the top, the gray is legal intervention, unintentional injury, and undetermined intent. So unintentional injury is a place that we'll come back to, because that's a lot of where we frame some of the child access prevention and counseling around safe storage. But I also want to highlight too why it's important to talk more concretely about individual risk and not just those accidents, which as a public health person, right, you never want to use the word accident. Nothing is an accident. You can prevent so many of these injuries. And then legal intervention, I'll also flag too that this represents about 500 deaths in in this data set, but we don't have a good way of capturing this data. The best available data suggests that that's closer to 1,000, 1,200 deaths per year. But again, because we don't have a national way of capturing that data, we know this is underrepresented.
Are you talking about police deaths?
Yes, yeah, sorry. Legal intervention would be officer-involved shootings. Yeah, thank you. Okay. Now, again, as a pediatric clinician, we'll focus in on youth gun deaths. So this is that same pie chart for firearm deaths among individuals under 24. And you see, right, that homicides are a much larger proportion of firearm deaths among youth. But we still see unacceptably high numbers of firearm suicides in youth, especially among subgroups. We know that American Indian and Alaskan Native youth are at disproportionate risk. We know that Black youth are at disproportionate risk and increasing in the last several years. And especially among LGBTQIA youth of color are at much higher risk of suicide in the last several years. So while it is a smaller wedge of the pie among youth, still a really, really important thing to be mindful of. Again, you won't be surprised to see that yellow wedge, the unintentional injuries, occupies a larger slice of the pie in youth and children. But again, a small number of overall youth firearm deaths. Yeah.
I noticed the graphs have a year attached to them. Mm-hmm. And I'd be curious to know if during the pandemic there was a difference, because people were isolated, more suicidal.
Yeah.
The effect of the pandemic.
A great question. I'll repeat. Did these pie charts look different, because of the pandemic, during the pandemic, and in contrast to pre-pandemic? Does that summarize adequately? So this is 2021's, and 2020 to 2021 were pretty similar. But like I said, if you look at 2017 or 2018, even 2019, then especially the overall ages does look substantially different because homicides occupy a narrower slice of the pie, closer to 35 to 40%, depending on the year. This I showed, these are crude numbers of deaths over all ages. And I show this because I think it's helpful to recognize what a disproportionate number of firearm deaths are suffered among youth, among young people, especially ages 15 to 35. And this is really important to tailoring clinical interventions, right? The ages at which we provide the general guidance for creating hospital violence intervention programs targets those specific ages. And that's based on this data, right? So these are evidence-informed, data-driven programs that we're trying to provide in a clinical setting. And so that's part of why I wanted to highlight this, right? That really important increase in risk in 15 to 34-year-olds especially. But again, recognizing this long tail there, right? We see a lot of injuries in those younger, early adult, later adolescence ages, but then a long tail of injuries continuing throughout the life course. Yeah.
Do you have the chart by sex?
I don't, but I do have this one. And so this shows the, so if you look at suicide decedents, about 87% are male. Homicide decedents, about 85% are male. And really, except when you're considering specifically intimate partner homicide, victims of which are disproportionately female, men are at a substantially increased risk of firearm deaths by suicide and by homicide. This, of course, I just want to kind of take a breath and a beat here, right? Because you see just this really stark health disparity that is, firearm homicide, firearm deaths, right? So that tallest light blue bar, if you can't see the text, is homicide deaths among Black Americans. And, depending on the city or what, data you're looking at, that risk is 10 times greater, 40 times greater to an age-matched white counterpart. So it's really, really important to consider, when we're thinking about designing interventions to address a really important inequity. You do see, I think it's also important to note the significantly increased risk among American Indian and Alaskan Natives, among whom we saw the biggest increase in risk of suicide from 2019 to 2020, 2021. So tailoring interventions that are appropriate for Native communities is also incredibly important when we're thinking about clinical strategies to reduce gun injury. And then highlighting too the difference there between white Americans, the lower light blue bar representing homicides, the higher dark blue bar representing the risk of suicide. I think I'll come back to that again later. Yeah.
Yeah, maybe you'll have something later about this, but do you also have numbers on an income basis? Does that wash out the race difference a little bit?
That's a great question. Does income, does poverty erase the race difference? And it doesn't, right? We still see dramatically increased risk among Black Americans, even when you're controlling for household income. Thank you.
Is there a contradiction between this chart and it seemed to me that Black American suicide and homicide, maybe I missed something, but there's that one, but you've got another one.
I don't have another, there was another slide showing, depicting race risk. One of the statistics that I did highlight on a previous slide though, was the increasing rate of suicides among Black youth, which you don't, yeah.
It looked like there were two variants.
Yeah. And even though it's, smaller overall numbers to where it doesn't show that there's, a higher risk of suicide among Black Americans, we do see especially certain subgroups, Black youth, Black LGBTQIA youth, who are seeing, significantly higher risk of suicide than in previous years. Okay, so we saw a lot of those individual level characteristics on different risk factors that impact risk of death by firearms, by suicide, by homicide, right? So age, race, but location also matters. And I think a lot of people are surprised to see that, well, first and foremost, firearm deaths are an everywhere problem. This is not an urban problem or rural problem. This is an everywhere problem. But you do see some differences. So I think a couple of things people are often surprised to see. One is the lack of a difference among different communities, metro areas, suburban or small metro areas and rural communities. There's not really a significant difference in the rates of homicides. But there is a substantially increased risk of firearm suicide, especially in rural communities, right? So why is that? What might that be related to? Maybe it's reduced access to mental health services. Maybe it's an increased prevalence of firearm ownership. I think probably all of these things play a role. But we see, firearm homicide is an everywhere problem spanning urban and rural communities. And firearm suicide is also an everywhere problem, but you do see an increased risk in more rural communities. Okay, so this is a quick infographic from our 2021 data report. I'll highlight there's hard copies of that over there because I know y'all can't see these from the slides, but they are over there on the table, and there's a QR code that links to the full report for those that are interested in more. So just a couple of data points to highlight, right? 48,830 lives lost to firearms in 2021, the highest number of gun deaths ever recorded in the US. This was largely driven, that's these little arrows over here, largely driven by an increase in homicides, but suicides also increased, driving that overall higher number. What an important health disparity this is, right? That Black teens and young men occupy or account for 2% of the population, but 36% of all gun homicides. But policy matters, right? So someone who lives in a state with less protective firearm policies like Mississippi is 10 times more likely to die by gun violence than someone who lives in a state with more protective policies like Massachusetts, like Maryland. So policy makes a difference. And we'll talk a little bit why, policy makes a huge impact, of course, but implementation matters a lot too. So how do we think about doing that, especially in my space as a clinician? And again, as a pediatric clinician, I can't not say repetitively, firearms are now the leading cause of death in children under 24, and really important for us to be mindful of, in all domains. Okay. I want to talk a little bit, I'll just drive through these really quickly, but just to highlight, right, that, those individual level characteristics matter, location matters, and means really matter, right? So this is just a chart showing the distribution of suicide attempts by mechanism. So that's 71%, that big wedge of the pie. This is a couple years old, these numbers, but still applicable and pretty close. 71% of all suicide attempts are by overdose. 6% of overall attempts are by firearm. Overdoses have about a 3% case fatality rate, right? There is a 97% chance that you will survive a suicide attempt that's made by overdose. But there is only about a 10 to 15% chance that you'll survive a suicide attempt by firearm. Firearms have about an 85 to 90% case fatality rate. So when you look at overall fatal suicide attempts, firearms are the leading cause or the leading mechanism for suicides, right? With 55% of suicides being due to firearms. Contrast to that teal wedge over there, which is about 6% of suicide fatalities being due to overdose. So really, really important. I think I highlighted this earlier, but this just adds a little bit of a graphic to what we were talking about earlier, showing that increasing risk of suicide, especially this is showing risk of suicide among Black high school students or Black high school students who've reported considering suicide in the previous year, showing that increase in risk in the last several years among especially Black young women and among Black and LGBTQIA youth.
Well, the pandemic started in 2020. So
yes, so we don't have
2019, that would be pre-pandemic, but 2021 would be during. So whatever comparisons we might.
Right. Yeah, I mean, I think, we hypothesized a lot about, children being in the home more, exposed to firearms more, more increased, depressed, social isolation, all of these factors, right? I think there were myriad factors that contributed to increased risk of suicide, but we started to see this increasing, long before. A couple things that I want to highlight from here, right? And we talked about this earlier, the risk of suicide by gender. We know that completed suicide deaths are predominantly male, depending on the data set again, 80%, 78% are predominantly male. But if you look at the peak in age, suicide risk peaks among Black Americans and among American Indian and Alaskan Natives at around age 20, whereas suicide risk peaks for white Americans closer to 80. So again, a really important difference to think about when we're thinking about risk and intervening for youth and for older Americans too. Okay. A couple of conceptual frameworks. And this is born out of a conversation that Chris and I had by email about the public health approach. Like, really, what does that mean? And also want to highlight the CDC's conceptual framework for designing violence prevention and firearm injury prevention strategies. So what is the public health approach, right? It's a cyclic, iterative approach to any problem. And really, I think you could address almost anything with this framework. It's a very nimble, adaptable, iterative framework, right? So first, what is the problem, right? What's the burden of the problem? How do we understand it? How do we, data, what are those numbers like we were talking about in the first few minutes? Okay, so what's the scope of the problem? We do that through surveillance. That's the first kind of reddish circle up there up top. then once we have this data, how can we break it down? Who's at risk? And what are protective factors, right? How do we emphasize those protective factors? How do we intervene on those risk factors? What are their causes? How do we, intervene upstream? So then we develop targeted interventions, what works and for whom. And then we scale up those interventions that work and repeat, right? So this is, again, an iterative framework for approaching any public health problem, but it's been, especially important and adapted to firearm injury prevention. But then how do we think about, identifying those risk factors, on what levels, developing interventions, and then that's where the social ecological model comes in. So the social ecological model is the conceptual framework that CDC uses for violence prevention initiatives, like I said. And I like this depiction of the model because it shows the interrelatedness of all of these domains, right? So individual level characteristics, right? Some of those are going to be immutable, like age and race, but others are modifiable. Then we look at relationship characteristics. And this is talking about your closest social circle peers, your family, your closest friends at school. Look at the community level, right? What is, thinking about blight remediation and poverty and access to resources, trauma centers, access to trauma and higher level care. And then the societal level kind of wraps around all of these things, right? Those are kind of the broader societal constructs that influence risk of firearm injury specifically in this case. But so when we're designing interventions to address firearm injury, we're wanting to act on multiple levels simultaneously and be mindful of how these different domains overlap and interact. So again, I think it's helpful to kind of have a model of how we think about designing these interventions and then how we think about where we're intervening and how. So just as food for thought. So next, I'll talk about a couple of clinical strategies to prevent violence, and then I don't want to, again, please interrupt with questions. I love it, but I do want to talk a little bit about some of our research. So again, we've talked a lot about risk of suicide, and I think that safe storage counseling is a really important place for clinicians to engage in firearm injury prevention, and it spans multiple areas. So I want to talk about lethal means safety and kind of the spectrum of safe storage counseling. So what really is safe and secure firearm storage, right? We talk about, keeping guns stored, unloaded, separate from ammunition, in a locked case, with the ammunition also in a locked case, right? But that's the foundation, right? And so with increasing level of risk, we have to afford higher levels of protection. So, safe and secure storage, that keeping firearms stored, unloaded, locked, that's the foundation. But then if you have someone who's at risk of suicide, homicide in your home, then you're thinking about higher levels of protection, right? You might be thinking about firearm removal through a voluntary transfer or through offsite storage or other means. The next higher level would be an extreme risk protective order, right? So an extreme risk protective order is a civil dispossession order, by which, the courts can order that firearms are removed from your home. All firearms are removed from your home. Again, this is about access, not ownership. So we've, in our state, seen youth be, respondents to ERPO petition, youth who are at risk of suicide, that we dispossess a household of firearms. But this is, again, a higher tier, right? So we're thinking about ERPO as being applicable for someone who is at imminent risk of harm to themselves or someone else. So I think it's really important to think about this as a hierarchy, right? That safe and secure storage is the foundation, and that ERPO isn't a replacement for safe and secure storage, right? We still need to be, extreme risk protective order. See why we shorten it. Yeah. So extreme risk protective orders are, it's more restrictive, right? It's more of, potentially interacting with someone's civil liberties. And so we don't want to go around dispossessing everyone of firearms, but we do want to potentially have these mechanisms for people who are at extreme risk or at imminent risk of harm to themselves or someone else. So I think I come back to this on a subsequent slide, but in Maryland, we as clinicians can be petitioners for extreme risk protective orders. So it is something that we think about in a clinical setting, right? How do we use this for, patients who are at high risk of suicide, but who don't qualify for, the most restrictive means of lethal means safety being an emergency petition. That's the EP at the top of the pyramid, right? And that would be, someone who's involuntarily admitted for mental health care. So, again, I think it's helpful to think about this as a hierarchy or framework to guide, for me as a clinician, how I'm approaching these conversations. Yeah.
This is all sort of foundational. All this is this concept that people have that having a firearm in their home makes them safe. And isn't it statistically accurate that it's safer to not have a firearm? And if that's the case, then how do you talk to people about?
Yeah, a great and really important question. I think I come back to this on a subsequent slide. I forget where I finally cut myself off on my number of slides today. But the question is, how do we really frame risk, right? Is a firearm actually, maybe statistically speaking, effective at, preventing or kind of interrupting a home invasion? How often are firearms used, defensively to protect one's family? And I'll say as a researcher, I definitely care a lot about that data. As an individual clinician, I'm usually not trying to counter that narrative. I'm trying to partner with a family to say, I understand that you own this firearm for personal protection and you want to keep your family safe. And I also really want your family to be safe. And here's another way that we can do that together. So I'm usually not trying to interrupt a narrative about, kind of the home invasion, concept, saying, well, actually statistics on defensive gun use, maybe don't bear that out. I'm much more trying to come from a place of partnership, and identifying, whatever their rationale is for owning a firearm. And I should say, that I'm a firearm owner too. So what is the reason? And then understand those reasons, and then, figure out a way that we can safely store your firearms to, safeguard your family from increased risk. But the data is really important to consider on a bigger picture level. But for us as clinicians in a clinical space, it's not usually kind of central to our counseling. Yeah. Oh, EPs are emergency petitions, or kind of an involuntary admission for mental health care. So we talked about that being we talk about ERPO, or extreme risk protective orders, being the most restrictive means of lethal means safety, right? Meaning, protecting you from access to lethal means, like medications, like firearms. But really, if you think about the broader civil liberties, emergency petitions are the much more, restrictive measure that one might have to take. Those are absolutely life-saving and necessary in some cases. But again, reserved for, a tailored set of circumstances done in partnerships with our colleagues in mental health.
My question has always been, okay, you have this ERPO order, you have the EP, whatever. How do you know that they own a gun, that they have surrendered their gun, or all their guns, It never really, because there's no record generally. I guess depending on the state.
Yeah.
You could also have a ghost gun.
Yeah. So, the question, how do we know that an ERPO has been effective in dispossessing someone of all firearms? How do we even know that an ERPO would be relevant or applicable, that someone has access to a firearm who might be at risk? And I think there's a couple potential answers here. One, if as a clinician, I start by asking more questions, right? And just trying to maintain a relationship and hope, that I'm getting, accurate and honest responses, but also recognizing that if I have someone who's at really high risk of suicide, so one of the contexts in which we're thinking a lot about using extreme risk protective orders as clinicians is actually on discharge after a psychiatric or mental health admission, that being a really high risk time for suicide. So then after we've had this time period of stabilization with a patient, then, might we consider petitioning for an extreme risk protective order at discharge or around the same time? Or for someone who may not qualify necessarily for an inpatient stay, is this something that we could do in partnership with a family? So one, on that point, I think your family is a really good source of information and will often know about access to firearms and can often partner with you in Maryland, especially to help petition for the ERPO, potentially not the clinician to petition directly, but actually have that come from a family member. But they can also inform your decision-making about how you conceptualize risk in the home. How do you know that all of the firearms have been removed? Certainly that's a risk. But when law enforcement comes to the home, they usually have more information on at least legally owned firearms to know at least a little bit better what might be present in the home. And certainly there may always be surprises, firearms that you didn't know were going to be there, types of weapons that you didn't know were going to be there. But the order authorizes law enforcement to remove all firearms, regardless of who the legal gun owner is, if that person is, the respondent is subject to a final ERPO order. Again, law enforcement tries to be really thorough when enacting these orders, but I think there is a risk, right, that a firearm might remain in the home, or there might be one that they didn't know about. It's very jurisdiction dependent, perhaps, but I'm seeing some nodding, maybe. But
they are not able to search the home, so they have to be told by the victim where the guns are. And the other problem is that during the pendency of a protective order, people go out and find guns. It's so easy to find the assets.
Yeah.
Really, it's fraught.
Yeah. An imperfect process, but a really important tool nonetheless that we know are really effective despite those imperfections, right? So I can highlight quickly just one piece of data, right? From states that have had these longer, we know that for every 10 ERPO orders completed, one suicide was prevented. Right. So, in medicine, I think about that as a number needed to treat. And most of the stuff that I'm doing in the ICU has a number needed to treat of north of 50. So it's really effective despite some of those weaknesses that we may see play out in the implementation. But that's where, some of my, colleagues who, I don't highlight the ERPO, National ERPO Resource Center in these slides, but, help with developing, training and technical assistance for different jurisdictions who are implementing ERPO to develop tools and strategies for how to make these maximally effective has been an incredible resource. Yeah, sorry.
Yeah, following up on the earlier point, I think I kind of want to go on for later in your pyramid at the bottom there, where you talk to your clients about, could we discuss what kinds of firearm? Maybe you don't need the assault rifle. Maybe you don't need 10 assault rifles. Could you maybe change the mix in some way and just to kind of deal with that distraction and somewhat cooperative client?
Yeah. And I think, how then do we, yes, we want you to lock them up and store them unloaded, but how then do we influence the decision to bring them into your home to begin with? And I think that's really a testimony to relationships, right? With your patients, for me, right? With family members, with, community members, right? That we're having open conversations about safety, about risk, about access. I think that, there may be more of an opportunity for that. For me as a clinician, I'm often not, again, I'm focused here, right? Because we know that more than half of people who own firearms don't store them safely. So I'm usually on the, I'm late to the game, right, in talking about these issues. And so really, I'm talking about mitigating risk from what's already there and maybe informing how people understand their risk about new firearms that they bring into the home. Yeah. Oh, yeah. A lot of ones. Good. Yeah. I'll start with you and then we'll go over. Yeah.
Safe and secure storage. I find that it must be a really challenging thing for gun owners to do, because if you're a hunter and someone who thinks safety is important, you probably unload those people probably store them unloaded and safely. But people who buy firearms or otherwise obtain them because they think they need them for personal protection or protection in their home or their family, I can imagine convincing many of them that they should support security. Store them safely, because they'll say, how could I get them in time and loaded in order to protect if there's an intruder or if. So I think that must be a really difficult task.
I'm so glad you asked that. How do we frame these conversations around risk to encourage people to adopt what might be, a difficult health behavior to adopt? And that's a lot of the research work that we're doing. And so, one, I think most gun owners actually see safe storage as a part of their responsibility as firearm owners. It's understanding risk and then understanding how to implement these approaches that really helps to change things. And I'll say I own firearms for sport. They are all kept unloaded, locked in a safe that's far away from everybody, because I don't own guns for personal protection, but I do understand that to a degree. And there is actually good data to support that you can still access a firearm quickly and store it safely, right? So we cite, old law enforcement studies that if you train with your device, right, if you practice, you can actually access a firearm from a key-coded safe in your nightstand in under 10 seconds and be able to use it to defend your family. So, I'll kind of, again, this is, part of the research work that we're doing. How do we grow the body of credible messengers around firearms, right? How do we, give clinicians access to that kind of information, right? I am a firearm owner. I've practiced, right? I know how quickly I can access my firearms if I needed to. So how do we then expose clinicians, many of whom are not firearm owners, to that information so that then they can bring that into their interactions with patients and families and potentially maybe change the course of one of those more challenging conversations, and I won't say that I've never, counseled someone who was, resistant to safe storage or didn't really see the applicability of safe storage to them. But the number is a lot higher on the opposite side, right? Where families want to protect at-risk people in their homes. They want to prevent theft. And once they understand tailored risk counseling to understand those things, I get a lot more uptake than you'd expect. I think having access to more information and more tailored information is really important, and that's part of what we're trying to accomplish through our study. You had a question, and then
One of the things that I hear you're doing is you're educating people. If somebody's been very depressed and they've been hospitalized, then they're most at risk for killing themselves that couple of weeks after that hospitalization. So helping them understand the fact that he's better now actually gives him the energy to kill himself. The suicide happens as you're recovering. It's not when you're in the deepest pit. You don't have the energy to do it, but you often do afterwards. And that's a huge education, and would, as a parent or a family member, would certainly make me want to get rid of anything that would be available to them. Right. As a lethal weapon. Yeah. Both medication as well as guns.
Yeah, I think absolutely. That's, in psychologic autopsies of, parents or close family members of youth who have died of suicide, we see that, right? That, even in states that, had an ERPO, that, when we failed to counsel, a family member didn't know that was available to them. And then, on a psychologic autopsy, they wish we would have provided them with that information, right? I wish I would have known this, I would have done it. I wish I would have known that, been able to understand this data, know when that risk period was, know how high risk this was and what means I could undertake to protect my family member, I would have done it. And so how then do we put that information into a clinical setting to help empower clinicians to go and have that counseling so that we can help to inform family members, community members about risk and how to protect at-risk folks. Yeah.
When you get out of the hospital, you're over the hump.
Yeah.
The worst part is coming, because as they get better, they have the energy. They don't forget that message, but now they have the energy to do something about it. They are most dangerous.
Yeah.
It's 10:00, so.
This is a hierarchy of safe storage. We've already talked about this. Gold standard being firearms. I can't not say this 10 times, right? Firearms are the leading cause of death in children under 24. Firearms should be stored in a locked gun safe, unloaded, separate from ammunition. Okay. And then I don't actually have a table of the study framework, but I do want to highlight some of what the center is doing and my role in the center. Is that okay? I'll do that. And then we can stop just for questions. So where I sit, the team that I lead is the clinical programs and practice team within the Center for Gun Violence Solutions. This QR code does not take you to the center's website as you might think that it would. This also takes you to the 2021 report. But I want to highlight, the many ways in which clinicians are engaged in this space. So my team consists of 27 clinicians across the specialty spectrum. Bedside nurses, nurse practitioners, PhD RNs, nurse researchers, physicians from psychiatry and emergency medicine, Department of Surgery and pediatrics, and others, all doing a range of clinically oriented research, advocacy, education around firearm safety and how we bring all of this information into a clinical setting, right? How do we take all that data generated from the public health approach to violence prevention? How then do we translate that into, at the bedside? So this just kind of highlights some of the work we're doing, right? These are kind of the domains that we work in: education, research, clinical program development. I haven't even mentioned our hospital violence intervention program being an incredible work that they're doing. And I lead our pediatric hospital violence intervention program and advocacy, right? How do we, train clinicians on effective gun policy and then help them to bring those clinical stories into their advocacy experience is also a really important aspect of some of the work that we're doing. But okay, I will stop talking and other questions want to hear from you guys. Thank you guys. Yeah.
Dr. Castle.
So I also am a clinician. I am not completely retired, but I have retired from the 15-minute visit. And I think that one of the problems is the problem of access to primary care. Mm-hmm. And when you get to a primary care doctor, you say, I have a headache. And then they say one problem, one visit, and you're out the door. And I think that until we, it's kind of like that, and get rid of a lot of guns. Certain things are so obvious, but are really hard to do.
Yeah. I think that's, so important, right? The time constraint is huge. And the clinical trial that we're doing now, developing educational programming and implementation frameworks for trauma centers, were designed intentionally, right? We have the luxury of time in the inpatient setting. So how do we figure out what works, what education is important, so then we can slim that down and provide a framework that can be done in a couple of minutes in a primary care visit. That'll be our next research stop, is the ED in primary care setting.
But I'm not sure that's possible. I think if you're going to develop, you have to develop empathy. You have to develop a relationship. If you don't develop that, your success is really not that likely. I mean, I know there's all these things. They're developing these tools so you can do it more quickly. But do you smoke? Stop smoking. That just doesn't work.
No, and sorry, I don't mean to say that this can adequately be done in 2 minutes, right? It is about a relationship. It is about trauma-informed care, right? It's about, relationships with patients and families and being a credible messenger on child injury prevention or injury prevention generally, or suicide prevention, whatever it may be, right? But to that point, our primary care providers have those relationships, right? So how then do we get education on accessing a firearm quickly for personal protection, should that be, a resonant factor for an individual family, right? How then do we get that education to clinicians who have that relationship, who have the opportunity to do, all the full spectrum of injury prevention counseling and anticipatory guidance with a family? How do we get that training and kind of counseling frameworks in? And, we know that when we train clinicians with, validated frameworks, we all love a framework for, kind of counseling on anything, right? If we can give them, a bit of a formula for how to approach this, right? Remind you, okay, ask more questions. These are the questions I can ask. A little bit of a script that you can play in your mind when you're having a challenging conversation, right? How do we get that to multiple domains across the House of Medicine? That's part of what we're aiming to do with our research. But
I just
thank you for trying.
I would just mention two other settings to do that. One is through education. I think Maryland has just passed. Any of my colleagues here, has Maryland just passed a law, Clint, requiring principals to send home information about safe storage?
Yes, there was a law passed that was started out to be mostly directed towards the firearms events and drills in the schools, but also included a lot of information for the public health community, to provide information to principals, to give to parents, and to incorporate gun safety into curriculums. So yeah, that was just this year.
Yeah, they now are going to have to notify parents about active shooter drills. If that makes sense for you guys from Ireland, it can be very stressful for students. And you made a quick mention of hospital intervention programs. That's a different setting. If you could talk on that for a second.
Yeah, hospital violence intervention programs are kind of on a really high level, right? These are wraparound case management support programs for survivors of assault trauma or their families, depending on the program configuration. So, these programs leverage engagement by, credible messengers, people with lived experience from communities to, meet a family when a patient, an individual, if we're talking about an adult, when they come in after an assault trauma, someone who's admitted with a firearm injury, stab wound, or after an assault, when they come into the hospital, then, a credible messenger, a violence intervention specialist, meets with this person, their family, and helps them to walk through their hospitalization, can be an advocate for them, and also then can partner with them to help them identify their goals, identify the barriers to reaching their goals, and then provide them with resources to help support them in their recovery. These programs, and there's, I'd commend you to the Health Alliance for Violence Intervention, the HAVI resource has a ton of information on hospital violence intervention programs, but really, really impactful programs. Speaking to Hopkins program in particular, if we look at our data on traumatic readmissions, people who are rehospitalized with assault traumas from before our program was implemented, our numbers were consistent with national averages, where there's a recidivist, I don't like that term, but a recidivism rate of 17 to 20%. After our violence intervention program, that number overall has dropped to 2%. In the last 12 months, it has been 0. So these programs are really, really effective at helping people to interrupt the cycle of violence. That's why our program is called Break the Cycle. Assault. So any, yeah. So recidivist injury could be a non-fatal injury, but an assault re-injury, by firearm, but other potential mechanisms also.
Clint, you have
I still wonder if you could talk a little bit about the community-based intervention and prevention programs, and especially, I guess, if you're in Baltimore, where the homicide rate is so high, how could they be more effective, or what's your experience with, if you have an experience with that, and what could be done to make it work better?
Oh, wow. A great question. And I am feel really fortunate to get to work really closely with a lot of our community-based programs. Some of the work that we're doing for the study is, not only how to counsel directly, but then how do we make sure that patients are getting access to the resources that they need after a hospital discharge. And so in so doing, we've been able to identify all kinds of community-based programs that even I, as a clinician, really, deeply engaged in this space, wasn't aware of. So speaking just to the resources in Baltimore, it's a really rich ecosystem of partners trying to intervene at different levels on this problem. And there's a couple of standout programs, right? One that would be the network of our hospital engaged violence prevention programs, some of which are also community-based. They're kind of hybrid hospital-based and community-based violence intervention programs. So think Safe Streets. If you may have heard of that model before, but also another organization called ROCA. ROCA engages with really high-risk youth, again, to interrupt those cycles of violence and help to, they use a method of cognitive behavior therapy to help interrupt those destructive pathways, to help people get access to different resources, a different path, different goals. They have educational resources and job placement resources. So, in Baltimore, we talk a lot about the violence prevention, that, we work in partnership with local government and all of these community partners, in addition to our, kind of healthcare partners, to try and intervene in multiple levels of that social ecological model to try and interrupt cycles of violence. I don't know if that answers your question, but there's a lot. Yeah, it's a huge web. And of course, many of our programs, right, we wish that we had capacity to take on more clients in our hospital violence intervention program. We wish that we had more funding to expand, X program in the community. But I will say that I think Baltimore has done a wonderful job and is, testimony to the important work of these, right, the reductions in firearm homicide that we've seen in Baltimore in the last year. But
Great. Yes.
Hi, thank you very much for your talk. It was very interesting. Just further to the conversation on education, I'm just wondering, are children and young people in schools in the US taught about gun culture and gun safety and perhaps spotting the signs in their friends and peers, or does that differ from school to school and state to state? Thank you.
A great question. I think this is going to be really district dependent, where you see firearm safety, right? Like how to safely handle a firearm. That kind of education may be being implemented adjacent to some school programs in some districts. Where I grew up, as an example. But then I think you see more of that, how do you know when your friend is at risk? How do you identify signs of mental health crises? How do you identify a friend who might be at risk of suicide? How do you intervene? How do you, inform people around you so that you can get that person help? And there's a lot of work on that being done in the schools. And I think the Association of School-Based Healthcare Systems do a lot of important work on training. I think especially in the School Nurses Association do incredible work around this, and getting those resources into schools, training for educators also. And then other groups, a really great research work, but also program implementation was done by a colleague of mine, Megan Ranney, who's now the Dean of the School of Public Health at Yale, working with 4-H programs. So these are youth who might be exposed to firearms for sport, but also then helping them to develop de-escalation techniques, active bystander training, identifying signs of mental health crises. So kind of a circuitous answer to your question to say that it's coming from a lot of different places, and directly in the school, it's pretty variable, but you see a lot of work kind of related to school systems that can be really impactful, and definitely in youth-oriented community programs, a lot of really good work too.
How about one more question? 1 second, because, okay, Deborah? And then we'll break.
Within the home, I see 3 different kinds of problems. One is the individual who's suicidal. Another is a domestic violence situation. You know, either of those could involve a firearm. The third, some people feel, rightly or wrongly, that they need a firearm to protect themselves in case of invasion of the home. And I'm wondering if for those folks, there might be some counseling along the lines of what else can you do? Whether it's locks on your door, having an aggressive dog, learning self-defense techniques. I mean, psychological, you know, how you talk someone down and away from doing harm. Yeah. But is that something you're also kind of on your radar screen? Is that on your radar screen?
Yeah, I really appreciate the question and the idea. And I think, you know, that is much less of the work that I do as a clinician, right? I think that's a lot more the work of our communities, right? And our families, and just having these conversations like around the dining room table, right? These are conversations that we need to be having in multiple spaces at the same time, I think, to have an impact on that. How do we get the data about personal protection, about defensive gun use, out into the community? I think, some others of my colleagues have produced some of that data and work with media and other organizations to try and share that information. But yeah, I think it's less of a topic for me when I'm engaging in safe storage counseling, again, because my fear, right, is that by invalidating your rationale for owning a firearm for personal protection, by saying, it's not really going to do that, right? I'm going to alienate that patient and their family. I'm going to compromise that relationship, and any opportunity I might have had to partner with them to prevent injury in their kids, I'm going to have lost. So on a broader policy level, yes, really important conversations to be having, really important data to be sharing. For me as a clinician in my space, that's not normally the conversation that I'm having. I'm not sure I'm answering your question completely, but yeah.
I think that's I have two wrap-up questions, and then there's lots of food. There's materials that Dr. Hoops brought from the Center for Gun Violence Solutions on this table, and in the back, Moms Demand Action, Maryland, which has done tremendous work, and also Marylanders to Prevent Gun Violence. My two wrap-up questions, $25 million for gun violence research in 2021. What I read is if it was commensurate with gun violence deaths and injuries, it would be $1.4 billion. So where's the funding at now? And at a macro level, since you've now got a law degree as well, what if you were given a carte blanche for two policies to implement to reduce gun violence, what would they be?
Is the funding where it needs to be? No. Is it better than it was, and will I take it? Yeah.
Where's it at?
The total allocations for this year, I couldn't give you a specific number, but it's so much better than it was 6 years ago. And it's expanded in those 6 years or in those 5 years, right, that I think it'll continue to grow from here, right? We have so much good research being done, I'm the recipient of an R01 from the NIH and the CDC, right? So I am a beneficiary of this funding, and this scale of work simply was not possible prior to federal funding being available, right? But in all of the time before that, right, that's not to say, right, violence prevention research didn't start 5 years ago, right? My colleagues in the center are testimony to that, right? We've been working on this with private funding, personal funding sometime, right, to bring this data to bear for, 20, almost 30 years now. So again, it's growing, okay, and it's really, really impactful, growing a tremendous body of research, encouraging a lot more people to go into firearm injury prevention research from a clinical space than previously. And again, I think it'll continue to grow from here. Okay, if I could pick two policies, what would I pick? I can't pick two, so I'm going to pick five. Right. So we have 5 policy priorities in the Center for Gun Violence Solutions. So a shameless plug again for the resources on the Gun Center's website. Right. Okay. Well, I'm going to start with safe storage, though. Right. So 29 states and DC have child access prevention laws. That's not 50. Right. So more states having more protective child access prevention laws. We know those are effective. They save lives. Extreme risk protective orders. We have those in 21 states and DC, not 50. Right. So again, thinking about state level policies, ERPO, we know that, those incredibly effective community violence intervention programs, funding, those community partners to do the really important and impactful work that they're doing in our communities, that works. Firearm purchaser licensing laws, also really, really impactful. I didn't even begin to show any of that data, but my colleague, Casker Fossey, has done really transformative research in that space. Those are incredibly effective policies. So anyways, can't pick two, but ERPO, safe storage, CVI, licensing. What am I forgetting? Oh, they're going to be so mad at me.
Well, I think we have to be honest and say guns are much prevalent in this country, and we're hampered by our legislators and our courts.
Yeah, if I could ask one thing to piggyback on the question of guns that protect your family. I've never seen data on the percentage of people who have protected their family and the percentage of people who have killed the wrong person using the gun, such as the teenager who was killed because he had too much to drink and he was trying to get into a house next to his and mistakenly he was killed. I'd really like to see the data on that.
Yeah, thank you.
Thank you very much. And please, there's a lot of food. Thank you very much.